Good evening and welcome to the final educational webinar provided by BOMSS for 2022. You've got myself, Emma Shuttlewood, clinical psychologist, and Nick Carter, surgeon, here this evening to host. And we've got a fantastic presenter that we will introduce in a minute. But just before I do that, I wanted to give you a couple of dates for your diary, for your next year's diary for 2023. So on the 11th of January, we've got our journal club, which will be Sharif and the Derby team presenting. There will then be an educational webinar session on the 25th of January. So make sure you've got those in your diary. Obviously, I want to say a thank you to Apollo for sponsoring the session tonight. And then I will hand over to Nick to do the introductions. Thanks.
Thank you, Emma. And yeah, as people are joining, we're very honoured to have Professor Perretta join us tonight. For those of you who don't know her, from those of us who've been dabbling in the endoscopy world, she's been at the forefront of promoting endoscopy by surgeons and as Vice President of EACAD in France in June 2019, and is an upper GI surgeon, a bariatric surgeon, endoscopist, and is pushing the forefront and has many, nearly 200 publications to her name. And the list goes on about what she's been up to, and it's a real honour that we've got you here in BOMSS speaking to us about endoscopy in the bariatric world. And I should also point out that you're on a course yourself in Brazil, so thank you for taking the time out to speak to us. We really look forward to hearing what you have to say. And hopefully all those joining and listening in, please, as Emma said, put your chat and questions in the chat, the Q&A box, so we can look through them and collate them and discuss at the end, as I'm sure there'll be lots of questions from the audience. So please think of them and just put them in as we go along, and we'll get to them at the end. So without further ado, I hand over to Professor Silvana Perretta to talk to us this evening. So thank you.
Thank you, Nick. Thank you, Emma. Delighted to be to join even virtually from Brazil. That's the beauty of Zoom. And I will share my screen. And delighted also to be speaking about a topic that I like very much, which is how flexible endoscopy can help us surgeons, and particularly how can we fix a very common problem, which is weight regain after bariatric surgery using flexible endoscopy, and particularly after gastric bypass surgery. We do know that bariatric surgery is not perfect. It's a very nice way of palliating a chronic metabolic disease, but sometimes just doesn't work. Most patients gain 30% of weight from their nadir weight, and up to 20% of gastric bypass patients can regain all the weight that they've lost over the years. And this is something that should not be surprising, because obesity is a very complex disease. And truly, we are just mediating and palliating a few of the over 50 different mechanisms that regulate the satiety and the satiation and the gut-brain axis. So no surprise to the weight recidivism that we can have after gastric bypass surgery. So bypass surgery, you know how it works. We are adding restriction and malabsorption, and by restriction, we are making a very little pouch and an anastomosis that should not be more than 12 millimeter in diameter. Unfortunately, this can change over time, mainly related to overeating of the patient, and this can result in weight regain. Of course, anatomy is one of the factors that is related to weight regain, and there have been several papers demonstrating the relationship between an enlarged gastrojejunal anastomosis or stoma and the weight regain, and some paper also analyzing the relationship between the size of the pouch and weight regain, which plays a less important role in weight recidivism. But the obese population is very complex, and we do know that there are other factors associated to weight regain, such as behavioral factor. And Emma is there to remind us that we always have to do a full and complete workup from a lifestyle point of view, including a nutritionist, psychologist, in order to understand why that particular patient regained weight before attempting any rescue strategy, even more so if we are thinking about doing a revisional surgery in this group of patients, which can be particularly complex. We do know that cases of revisional surgery can be more complicated than a primary bypass, and we do know that even after we have performed the revision, those are patients that will often, up to 13% of them, will require a third operation, which also could be complicated. So it's not an easy surgery, it's not an easy problem to fix. There is no perfect solution, which is the case, often the case with the bariatric population. So what can we do endoscopically? First, or what can we do in this patient? First of all, multidisciplinary approach, and I insist a lot on these. I do not do any endoscopic revision in patients who did not join the multidisciplinary team and did not go back to the nutritionist and the endocrinologist and the psychologist. So once this is done, and once they are compliant to the lifestyle rules and regulation, again, then we can propose them to do an endoscopic revision. All the literature is mainly focused on the size of the stoma, as we were saying before, because it's the one factor that is associated to weight regain, or mainly if you reduce the stoma, to weight loss after the stoma reduction, which was demonstrated almost 10 years ago by Chris Thompson. Very recently, what we also have long-term results of stoma revision, which can be done by a variety of means, but today there are mainly two methods. One is the use of simple APC around the anastomosis, so burning the tissue of the gastrojejunal anastomosis, creating a halo of about 1 centimeter, or combining full thickness suture, and today mainly using the overstitch device from Apollo Endosurgery with APC, or suturing alone. And you can see here that the combination of this different techniques may be capable of doing, first of all, stop the weight regain in this patient. So really prevent this patient from gaining more weight, which is already successful if you address the problem when the patient are starting from their nadir weight of gaining the weight back. And at 5 years, which is a pretty long follow-up with this particular technique, you will see that up to 62% of patients will present a total body weight loss of 5% or more. This is, to me, and in my experience, is not a single stop or single shot procedure. Most of these patients, and it's the same in the different studies that you can find in the literature, will require another go, will require a touch-up procedure, most likely by a second APC intervention, or a second round of suturing in order to improve or preserve the weight that they have lost. There are different techniques. Endoscopists and surgeons are very creative in this particular world. I think every single suture pattern has been attempted. Most of the publications are not from surgeons, they are from gastroenterologists. And you can see, and I say this freely, suture patterns that are a little bit weird or do not make sense to me, being a surgeon. But if you look at the literature, the one that seems to have the best results in terms of a short-term weight loss is the purse string patterns with sutures that are taken all around the anastomosis. I will tell you why I do not like this pattern in a second. When we compare the use of suturing and suturing plus the use of APC, and we look at the literature, it seems to be more effective to use a combination of those, although there is no clear difference at a short-term follow-up at 3 to 6 months. If we compare the techniques, it is clear that associating two effective ways of reducing the size of the anastomosis has better results over time. So this is how I do it. And this is one of my patients that I actually did a couple of weeks ago. And the first thing you can see is that there is food in the gastric pouch, which is always a red flag. This is a patient that, of course, had to be fasting for the day before of the procedure, which she clearly did not do. And this is a nice case because you have a very large anastomosis. We can discuss how to determine the diameter of the anastomosis, which is something that we rarely do, but it will be extremely helpful in standardizing the technique and understanding the results that we have. I'm touching it up with the with APC. I like to use precise APC at 60 watts. And since I'm adding, in this case, some sutures, I do not do a halo that is 1 centimeter. I like to have half a centimeter halo. And here you see a 15 millimeter snare that is placed over there just to have an assessment of the size of the anastomosis. You can use a larger snare, or you can use some other ways of measuring it. You see here the use of the overstitch device, and this is the Gen 2 device. Of course, you can use the S6 device too. So why I don't like a purse string pattern? I like to place multiple stitches because if one of the stitches come off, you have the protection by the others, and I like to reinforce them. Now, if you're not familiar with endoscopic suturing, I would recommend you use the overstitch device first in an endoscopic sleeve gastroplastic technique, and then you move to this one here. Why? Because sometimes, and this is an easy case, sometimes the space that you have, your working space, is very limited, and it can be tricky to maneuver the overstitch in such a limited space. So what I do here, I am placing a triangular stitch and then assess the results of this first stitch before placing a second stitch. So the use of multiple stitch also allow you to really tailor the diameter of the anastomosis, which should be about 10 millimeter in diameter. And I really want to be capable of seeing the jejunum on the other side. And although we do not pass the double tunnel scope because the diameter is too big, you have to have a lumen that is still preserved in order to prevent outlet obstruction, which can create vomiting, which will decrease the strength of the suture. It could also, in some extreme case, lead to perforation, which is definitely something that you don't want to have. Very important to get full bites and not only the mucosa, but the full thickness of the anastomosis circumference. So here we're getting not only the gastric side, but also the jejunal side, and then gently close. Once you've placed your second stitch, you can decide whether you want to place another one. If you're starting this technique, I would recommend to stick on the X greater curve of the stomach and don't start on the lesser curve of the stomach for obvious anatomical reason. This is a patient that has a very large pouch, and I'm safe aiming at the lesser curve. But in a very, very small anastomosis, I would recommend to stay on the left side of the screen and on the greater curvature. Here we're placing a second stitch. Once again, full thickness sutures, making sure to be very stable and to avoid all manipulation that are not perfectly controlled, because once again, the space is small. You can use the helix device to ease the tissue into the suturing device, or you can simply bite the tissue directly with the curved needle, as you have seen in this last bite that we have taken. So for a surgeon, you use the suturing pattern that seems the most adequate in order to in a controlled fashion to reduce the caliber of the anastomosis. And if you're using a purse ring suture, it is very difficult to control the final lumen of the anastomosis. Also, you cannot predict how that particular patient is going to react to the APC. The effect of the APC and the edema and the scarring that the APC can cause is very difficult to predict when you're doing it, and it varies patient by patient. So this is the other reason why I don't like to be too aggressive. I can always go back in this patient and touch that anastomosis up with the APC again. Now here, I decided to work also on the pouch, and this is a nice case because it will show you both a possibility using this system. I do not use APC to touch up the pouch. I just use sutures, and I do not use APC on the gastric side when I do endoscopic sleeve gastroplasty. I believe the suturing for this particular step of the procedure is just enough. What we want to do here is also redirect the flow of the bolus of the food towards the anastomosis. One of the reasons why this patient has a such dilated pouch is also because you see that the anastomosis is really totally onto the right side of the screen, so it's not in the right axis. When you do bypass surgery, this is something that really you should pay attention to, and if you add endoscopy during your procedure, endoscopy can help to have a straight shot when you're doing your gastrojejunal anastomosis. So first ring suture in this case, I'm doing exactly the same U pattern that I use when I do a endoscopic sleeve gastroplasty. I tend to use a limited number of bites, maximum 6 bites per suture. This will allow me to have a much stronger suture and to have something that will stand the test of time. Now here you can see that I'm pulling with my Helix device, and I'm asking my assistant to unscrew the helix. Why is that? You could see a bulge, and I did grab something that was outside the gastric wall, most likely some fat, but in this case, I prefer to re-grab and make sure that the tissue I have is flexible enough so that the stomach and only the stomach will be sutured and cinched. The first suture is placed. After flushing the channel, we go ahead and place a second suture because you can see that the gastric pouch is still very big. And same mechanism. So we go onto the, I would say, anteroposterior wall of the stomach, all the way up towards the, traveling towards the gastroesophageal junction. And exactly as we have shown before. So the use of the helix, we turn the helix 3 times and ease the tissue and making sure we grab the tissue perpendicular to the jaws. This is something very important if you want to get full thickness suture. The fact that the needle is a big, strong, large needle doesn't prevent you from doing mucosal to mucosal bite. You really have to understand the interaction and the dynamics between this sewing machine and the tissue. So you see always bites that are perpendicular in order to grant full thickness. And what I like to do, I like to pass my helix in between the 2 sutures so that my suture is not trapped and I can slide in nicely before cinching it. What I'm doing here, I'm also protecting with a big metallic tower on the needle side, the structure on the posterior wall, so that I'm sure that I don't grab the pancreas and I don't grab anything else, as you can see here. So this is a good case if you start. I would recommend that you start with a with large stomas and large, even more importantly, large pouches, simply because it's easier. You can move, you have space. If you have a very little space, it's more complicated. I'm just going to speed it up for the sake of time. This is going to be our last stitch here. You can be even more aggressive if you want to, but once again, the beauty of endoscopy is that it can be easily repeated with not added morbidity. This is another case that I've done it's a live case that I've done in Rome a couple of months ago, and you can see that it's a totally different situation. They did not give me a present with this case because you can barely access the anastomosis. So this is a case that is much more challenging, both for the APC, because you cannot APC the small bowel; it will turn into a secondary perforation, and because you have very little space to maneuver the suturing device. So the first step consists in, of course, passing the APC and then into suturing. And you can see here how much more complex is to maneuver the suturing device. This is the newer device, the S6 device, when you're in a very tiny space. With experience, it is feasible. But don't start with this case because it's a little bit more complex. One of the reasons why it's more complex is because the device is fixed on the scope, and when you don't have space, you cannot rotate 360 degrees, especially if you have an orthoscope device. So it is a little bit tricky to grab a full thickness bite and something that makes sense. Of course, you can just place a suture, but if it's just a mucosal stitch, it will not hold, so that patient is not going to be treated by your intervention. So you can see that we need to take the time to really position the curved needle in a way that it will take a good bite of the mucosa. You have to pull back the device to exchange the needle and be very gentle, pushing with the needle exchange device the tissue away. This is something that is not difficult to learn for surgeons because you're used to suturing. Is actually pretty straightforward for somebody who's already experienced in endoscopy to learn this device. I found that gastroenterologists have a little harder time in mastering the device, just because they're not used to suturing so much as we are. So even in tough cases, it is doable. And of course, this is something you can do for patients who present dumping syndrome. And this patient presented both weight regain and dumping syndrome. What are we doing now? We're just slowing the inlet of the bolus into the jejunal, the jejunum, in order also to prevent and reduce dumping. Another technique that I would really discourage you from doing is something that we were doing at the beginning, and this is this Swanstrom that I'm sure everybody know. This was back almost 10 years ago, I would say. So what Lee would do is not only APC the jejunum, but in some cases he would also use a mucosal ablation, and I would not recommend it because in my opinion it is a little bit dangerous, and you are really scraping all the tissue from the anastomosis, which can weaken the anastomosis itself and can result in edema, in a lot of edema. And when you have a lot of edema, what you have is an outflow obstruction, which can result in perforation. We did have 2 cases of perforation with this technique. that I had to take back. It was not easy. So my piece of advice for you is do not perform mucosal resurfacing with EMR, endoscopic mucosal resection, before applying the suturing device. APC is just enough. So in conclusion, I think that this is a beautiful technique, is the technique I choose when I have patients with weight recidivism after gastric bypass. It is effective in arresting the weight regain, which is not a small thing in this category of patient. The weight loss is variable. Although the latest studies show up to 8% of total body weight loss, which is preserved at and present at 5 years after the procedure. Most of these cases require multiple treatment. Most of these cases also are patients that are compliant to the follow-up. I do believe that the combination from a technical point of view of APC and full thickness suture is what's going to grant you the best results. I'm not a fan of purse ring suture. You understood that, but there is a lot of variation, technical variation out there that prevent us from having clear results in terms of weight loss and long-term life of the sutures that we place. There is a lack of guidelines. We don't know when is the best timing to perform this procedure, which again is the best technique. So I encourage you to do randomized trials on your own patients in order to help us see through this particular problem and come with an answer. Lastly, I'd like to say that if you fail, whenever you fail an endoscopic procedure, it almost never prevents you from a revisional surgery. It does not make surgery more complicated. If the sutures are still there, it is absolutely not a problem. You can staple over the suture. I would recommend that you always perform an exploratory endoscopy while you're operating in order to understand the anatomy and to guide you with your stapling. Thank you very much.
That's fantastic. Thank you so much, Professor Perretta. That's amazing. And so nice to see all the data and your amazing videos. While the questions come in, just to start off, you're obviously very experienced and do a lot of these procedures. Are there any cases that you feel should go for surgery rather than endoscopy treatment?
Thanks, Nick. That's a good question. I think that I always try endoscopy because it's safe, it can be very effective, and it really gives me the time to work with the patient and with the multidisciplinary team. So I would say no, there is not. At the beginning of the experience, if I had a very, very small pouch, I would be a little bit more uncomfortable using both APC and suturing, and might use only APC. But with experience, you can use suturing also in smaller stoma. But I would not. I would always go for endoscopy first.
That's interesting. Thank you. And this is still not very well taken up in the UK, mainly for access and lack of referral patterns. How common is it in France and in the areas that you visit? Is this now taking over from laparoscopic revisional surgery and robotic revisional surgery, or is it still lesser taken up?
No, I think that this is something that French surgeons are willing to do more and more. First, because they learned that revisional surgery, even if you do robotically, is not easy. Second, because they've learned it's not always the obvious solution to a very complex problem. And I love operating. I'm a surgeon, but I also love my patients. And before proposing them something that is much more aggressive, I'd like to use an in-between step, I would say. And that is why a lot of surgeons are adopting this technique. And if you don't know how to suture, you could do, a step-by-step approach. You could use APC, which is something I do when I see that a patient is not particularly compliant to lifestyle changes. It's not expensive. You can do it. It's very safe. And then the patients come back and you reassess the situation. So it's very flexible. Endoscopy, it is a very flexible tool.
Thank you. Emma, some questions in the chat box?
Yeah, well, actually, selfishly, I just wanted to ask one of my questions first, if that's all right, Nick. Sorry.
Go for it.
Sure.
Got a few jotted down, but I won't. I'll go to the Q&A box next. I wondered, because you were talking about it arresting weight regain, and I wondered kind of whether there was a sweet spot or kind of, what level of weight regain, when would you be looking to do this? Because presumably you want to kind of get in early, but how do you decide when to do it, if that makes sense?
To me, any patient who starts to approach a BMI of 30, it's a red flag.
Okay.
Any patient that, and of course, patients who did reach BMI that is less than 30. So any patients with a BMI of 30 is a patient that I start putting in my list of potential revision.
Yeah.
But of course, not all the bariatric patients are capable of achieving a BMI that is less than 30. So if you see that you have a progressive increase of weight after you have put the patient through 3 months of aggressive follow-up, that is the perfect timing for me. I don't wait for patient to regain a massive amount of weight back. And fortunately enough, we have very good follow-up. We have more than 90% of our patients that come back even 5 years from surgery, because this is a problem that you could have at 1 year, at 2 years, at 3 years, at 5 years, at 10 years after surgery.
Wow. Okay. That's amazing. Maybe that's a different question, not for today, but I want to find out how you have such a high retention rate of your patients, because I don't think we have anywhere near that in the UK to be keeping patients.
Very impressive.
That's amazing. So yes, we have had a question from Harry on the chat, which says, what is the learning curve for performing these procedures?
For APC, I think you just have to watch one and perform one under supervision. APC is not a difficult technique. You just have to understand that hitting the bowel with your APC is not good, and to be very precise. I don't think that any experienced endoscopist or surgeon would have endoscopist would have a problem with that. Suturing, once again, it's more complex, and I would not recommend to start with this procedure. I think that you will learn about 10. You will need about 10 procedures to be comfortable to do this by yourself independently. So the best way is to learn how to use the device in a lab. You do not need any in vivo training to learn how to master the procedure. Do some ex vivo training, do in vivo labs, and do training under supervised mentorship when you do the first cases. And if you have the opportunity, go and watch an expert doing it, because you will learn so much being in the OR with an expert.
Thank you. I think maybe one last question for me, if I may, as host prerogative, is you talk about the helix staying away from the lesser curve, presumably so you don't reach the big vessels and cause bleeding. I mean, how often do you find that your helix goes through the wall of your anastomosis or stomach and actually causes a significant complication?
This is a very interesting question. I don't have it for my talk, but we have very nice videos of revisional surgery after failed endoscopic sleeve gastroplasty, where you see that the helix, especially on the anterior wall, because that's where you see it most, will reach and grab the peritoneum, and you will find these lesions between the anterior gastric wall and the peritoneum. So the helix goes through the stomach, and if you are not careful in managing and really tailoring your grip of tissue, your bite, you will get structures that are outside the stomach for sure.
Thank you. And I think we've got one more question here. The one anastomosis gastric bypass, mini gastric bypass, do you recommend endoscopic treatment for that, for anastomotic dilatation?
You can, yeah, of course, you could attempt that too, and there are a few case studies in the literature. You could do that. Then it depends if weight regain is the only problem that patient has.
Okay.
With this kind of surgery.
Emma, shall we think about wrapping up there, because there's only a couple of minutes left?
Yeah,
unless there's any more questions anywhere.
No, well, I'll ask a sneaky another question. Sorry, just because I'm interested, and I never get to look at this stuff very much. Obviously, I make quilts, so I sew quite a bit. So I'm presuming that's just really similar. But no, I'm only joking. I was wondering about the fact that I suppose with the patient that you showed in the video, they hadn't fasted, and I suppose would you ever kind of, how would you manage that as a team? I suppose if there's evidence that I suppose they're not following even the advice for a procedure. Do you know what I mean? Would that be something that would be discussed afterwards, or?
Absolutely. It's a very, of course, I yell at them, and I think that we all do when they don't. And yeah, no, I mean, with bariatric patients, there is a lot of discussion, a lot of talking, and if you don't do that, they just don't listen. Most of them, not all of them. That's why probably we have good follow-up. We really take the time to talk to our patients, and we have very good nutritionists that take care of that. With this kind of patients, what I usually do, I shorten the time in between visits, because I want to make sure that they follow exactly what they're told to. And when you're very aggressive with that, you usually have better results.
Yeah.
But
and do you think there's a difference? Would there be any contraindications, or I suppose any factors from a behavioural, psychological or dietetic point of view that makes this procedure a better option or makes it a less better option? Sorry, that's not very good.
Yeah, no, I think that this procedure is a better option because once again, the category of patient that will have a problem with weight regain, especially if it's large weight regain, are very difficult patients from a psychological, behavioral, surgical point of view. So this kind of procedure is something that is at a very low risk, especially if you use only APC.
Yeah.
So you can follow the patient, watch the behavior of the patient, see how they do afterwards, how well they comply with the multidisciplinary follow-up, and then decide whether the results is so good that you will keep going endoscopically, or that it is a patient that will require surgery. Yeah. But it's a tool that you can have as a surgeon in your armamentarium to try to understand how to stratify this very difficult group of patients.
Yeah. And is there any kind of, I suppose, with the patients that have responded better to this kind of treatment, and I suppose it has stopped the weight regain, or even that they've lost, up to another 5% or something, is there anything about the behavior, or do you think those people are complying better with the kind of nutritional and the follow-up guidance, or is it something more anatomical or medical that kind of means they're going to do better following this procedure?
I think it's a mixture of both. I think that obesity is extremely complex, and it would be a little bit limitative to say it's just behavioral or it's just anatomical. I believe it's never just anatomical for sure, but sometimes you do have an anatomical cause that enhances the weight regain in these patients.
Yeah. Brilliant. Okay, we've actually just had one more question, if you're okay, because I think we've got till quarter to.
Yeah, sure.
Yeah. So yeah, Barris has asked, did you use this technique for a patient with bipartition? Do you think it would be effective for obstructing pyloric passage in this setting?
Yes, I have. It is obstructive. It is effective immediately. I'm not sure about the long term. Yeah. So it always looks beautiful when you are done with this procedure. They are perfect. When you go back, not so much. So I don't have an answer to that. It is possible though.
Oh, perfect. Brilliant. Well, yeah, I mean, Nick, have you got any other further questions or?
No, I mean, it's been really interesting, and the question were answered. So thank you so much. It was really, really good, Professor Perretta. We're very honoured to have had you to deliver that talk to us here in the BOMSS group. So thank you so much.
Absolutely, absolutely.
Thank you very much, and Merry Christmas.
Ah, thank you. Thank you. Well, yeah, Merry Christmas to you. And obviously, Merry Christmas to everybody that's here watching us live this evening. Please don't forget that all of these are recorded, so they're available on the BOMSS YouTube channel. So, you know, tell your colleagues, anyone that couldn't be here tonight, then let them know that they can watch back on those. Just an extra thank you, obviously, to our fabulous presenter and also to Apollo for sponsoring the event this evening. A reminder for those who joined maybe a minute or two late that the dates for your 2023 diary are the 11th of January, when we'll have Sharif and the Derby team presenting for the Journal Club. And then on Wednesday, the 25th of January, will be our first educational webinar. So from everyone here this evening and from BOMSS Council, we'd love to wish you a very Merry Christmas and a Happy New Year. And hopefully we will see you all very well rested, hopefully most of you, come January next year. Okay, thank you.
Thank you, Emma. Thank you, Professor Perretta. Happy Christmas all. Bye-bye.
Bye-bye. Happy Christmas. Bye-bye.